Good evening, everyone. My name is Jenny Gallagher. I am one of the one of the two chairs of the Workforce Education and Training Special Interest Group, and I'm delighted that Dr. Raki Patel has joined me as co-chair. As I mentioned before, this group really evolved from the Dental Public Health Education Group, and now we're interested in workforce education and training. And as you will know, in the new system in EADPH, we're trying to have more webinars during the year. And that means that people who perhaps want to dip into education, but have got an interest in one of the other groups, can also join these sessions. Or if people can't actually make it to a conference, there's a chance to engage during the year. So it would be lovely if you would email me afterwards if you've got any thoughts or suggestions. I'd love to hear from you. But we've now got 23 people in this meeting, which is really exciting. And I'm absolutely delighted that we're going to tackle the issue of education. And this was something that we'd been looking at over a number of years in the previous special interest group, but it remains very much foundational because dental public health as a discipline has a limited slot within undergraduate education. And it's a great opportunity to influence our students, some of whom may come into dental public health. Others, actually, we just want them to use a dental public health approach, whether it's on the front line clinically or whether they end up in leadership roles. So what we do in education is really important. So I'm delighted this evening that Professor Rob Whitten, who's a specialist and consultant in dental public health. He's professor of community dentistry at Peninsula Dental School in the University of Plymouth, and he's got a whole range of interests, which I won't list because you've already seen them on the CVs that were circulated. But he's been at Peninsula since 2008. And I had the pleasure of being an external examiner and just to get some insights in the innovative ways they were in this new it's maybe not quite so new now, but it was new then, dental school. And so I'm delighted that he's going to speak this evening, along with one of his postdoctoral fellows, Dr. Anastasios Aplesas. So without any further ado, I'm going to hand over to Rob to introduce and start off the talk. We'll probably go through that for about half an hour and then have time for some questions and hope to finish on the hour. So thank you very much indeed for joining. I'd ask you all to keep muted during this presentation. If anyone unmutes, I do have the controls to remute you. So at the end, when we get into discussion time, that will be the chance to be able to engage. And if you've got questions on the way through, there is a chat function, which I hope is working. Yes, it is working because thank you to colleagues who've put some posts in it. So we know that's working. So please do put your questions in it as we go through. So thank you. Rob, can I hand over to you, please? I will go on silent and you should have the function to be able to share your slides. Thank you for your presentation.
Thank you, Jenny. So I just want to check everyone can see the slide okay and everyone can hear me.
Yes.
Hopefully
The slide disappeared a little while ago. If you can put the slide back up again.
no, it's disappeared.
Yes, just take it down and reshare it.
Yeah, I'll do that again.
Technology likes to keep us on our toes. That looks like it's coming through. Perfect. Looks good. Thank you.
Is that through now?
Brilliant. Thank you.
Okay,
Good to
lovely.
go.
Okay, so Jenny's explained the purpose of the presentation today. So I'm going to kick off the slides, and I'm going to hand over to Anastasios, who's going to do most of the heavy lifting tonight. And then we'll hopefully finish in good time. So there's plenty of opportunity for some questions and discussion at the end of the session. We're very acutely aware that there are many examples of delivering dental public health education across the UK from speaking to colleagues and also across Europe. And we would like to hear about some of those as well. So Jenny's mentioned. Oh, I think this Our slides have stopped,
Sorry,
sorry.
sorry.
Ah, Jenny's mentioned the learning outcomes, what we're going to cover today. So we're going to do a very brief intro into dental public health within a UK context. And then I'm going to hand over to Anastasios, who's going to talk a little bit about the conceptualization of social accountability and how that fits within the UK General Dental Council learning outcomes. And then it'll come back to me, and I'll do a short presentation on how we deliver this at Peninsula. And then, like I said, we'll have some opportunity for some questions at the end. So I thought to set the frame for the discussion tonight, it would be worth discussing dental public health in its context within the UK. So as many of you will be aware, it is a recognised specialty in the UK, one of the 13 registered dental specialties. But at undergraduate level, all dental schools have to demonstrate learning outcomes according to the regulator, which is the General Dental Council. And from August 25 this year, there is a new framework being introduced called the Safe Practitioner. And within that, there are some new learning outcomes within dental public health. And one of those is social accountability. Hence why we're going to focus on that a little bit today. Social accountability is still a new concept, really, within dental education. It's much more developed within medicine and the allied health professions. So it's still relatively new and something that I'm sure that all schools across the UK and across Europe are going to need to tackle. So I'm going to hand over to Anastasios, who's going to talk a little bit about the concept of social accountability and what that means.
Hello, everyone. So, social accountability was introduced initially for medical schools by the WHO in 1995, and it is defined as the obligation of the schools to direct their education, research, and service activities towards addressing the priority health needs of the community the schools have a mandate to serve. In the literature, the terms of social responsibility, social responsiveness, and social accountability have been used interchangeably, which makes the contextualization of the concept of social accountability and its application to dental education slightly difficult. They do differ, and there's a subtle but substantial difference between the meaning of these terms. They all lie on a scale, and there is a linear progression towards achieving social accountability. So social responsibility refers to just an awareness and an interest in health inequities and social terms of health. When responsiveness, social responsiveness refers to a course of action addressing society's needs, which involves engaging in activities to address the health inequities and social determinants. Social accountability is higher on the scale and incorporates the other two, but the main difference is that taking a social accountable approach means that we predominantly involve and engage and work collaboratively and in partnership with stakeholders like the public, civic society, and organizations and communities, including those most vulnerable or undeserved groups of the communities that are likely to experience the worst oral health inequities. If you look at this table, for example, also as educators, what we try to achieve is, what we thrive to achieve is get graduates in a level that they can be agents of change. And also the taking a social accountable approach means that we are looking at the impact that our educational strategy and institutions can have to the community and the public health of the communities we're serving. And also, the community is an active partner in our educational strategy. In 2010, the Equity Network was developed in an attempt to develop an accountability framework, which is now live, and help the institutions to align their training with social accountability principles, focusing on evidence-based practice, people-centered education, with the utmost aim to reduce health inequalities and address social terms of health. Social accountability has also become an indicator for excellence. In 2012, the Association of Medical Education in Europe launched the Aspire to Excellence Awards, and the industry became part of that in 2014. We can move. Moving back to the NET framework, they have, we put this website here for people that may be interested to find out what that's about. On their website, they have the whole framework and the toolkit, which can help schools to develop their strategy, but also assess the impact their institution has in the community, in the health of the community or the area or the nation they serve, health equity and health systems. And the framework takes, the philosophy of the framework is rooted in theory of change, and emphasizes the importance of continuous needs assessment, stakeholder collaboration, and regular evaluation, and in order to keep the educational program effective and responsive. We missed a slide. Oh, there was another slide somewhere. So in the European I think it's later. Can you go to the next one, please? Lovely. In the European context, our chair, Professor Gallagher, had co-authored this paper, which outlines the position and the requirements that the Association for Dental Education in Europe has over the EU graduates. And within this paper, it's recognized that dentistry takes place in primary care, and the graduating European dentist should take account of the wider context within which they practice. They should integrate effectively in society, and they should advocate for general and oral health and system change. So in the UK context, responding, I suppose, to all these sort of calls for action, the General Dental Council has updated their it's called now Safe Practitioner Framework, and social accountability appears in this framework under the umbrella of professionalism. And as educators, we should be equipping our students to be able to demonstrate, or UK graduates to demonstrate professionalism and integrity, and help them to behave ethically and also show leadership and social accountability. The graduates should be able to be committed to advocate for oral health, promote good oral health, and understand the importance of sustainable self-service provision, but also being able to address priority health needs of the communities they serve. And we can see how this GDC framework maps on the WHO definition. Lovely. So again, the clinical training for students and the input, the public health training within the undergraduate and postgraduate curriculum should have is to prepare practitioners to commit to the health of the communities they serve by identifying the social determinants of health, be able to respond to the changing needs of the community, and advocate for these needs to be met. Adopting the social dentistry concept that Beddoes et al. Introduced, we suggest that our public health training and clinical training should equip the graduates to be able to provide patient-centered care and be aware of the community resources in the area they practice, and be able to signpost people in order to address what makes them really sick, which is the social determinants of health. The community level students should be equipped with the necessary skills to adapt their practice to the needs of the most vulnerable groups of their community, but also advocate for healthier local policies. And at a societal or system level, if you like, students should have the skills in the future to engage in upstream actions and which will address the social determinants of health.
Thanks, Anastasios. So, as Anastasios has highlighted, there are a number of frameworks and toolkits that can help institutes to develop social accountability pathways. But having said that, it is still quite challenging to develop innovative teaching methods for this. So I was going to cover a little bit about how we do this at Peninsula. As Jenny mentioned at the top of the meeting, Peninsula is a relatively new school. It was established in 2006, and the first cohort of students commenced their studies in 2007. So in many ways, it was relatively easier for us to introduce society and social accountability into our curriculum. And as you can see here, that the PDS stands for professionalism, dental skills, and society. So social responsibility and accountability has been really one of the DNAs of the school ever since its inception, which I know gives us a slight advantage. The other unique features of the school are that it is based in primary care. So that also brings the school quite close to the communities it serves. Our facilities are spread across a wide geographical area and sited in different communities, which also enhances that societal response to oral health needs. So, in terms of our curriculum, I thought it'd be really useful to just to explain how we integrate the community curriculum into the curriculum overall. So, the curriculum at Peninsula is built on four main blocks. You can see those at the bottom of the screen: integrated dental science, clinical dentistry, professional development, and this one called interprofessional engagement. And interprofessional engagement is a cross-cutting theme which spirals all the way through the curriculum up to the point of graduation. So you can see here that it encompasses several different modules throughout the different years. But in the early years, those are focused on community exposure. And I'll talk in a moment about how we use the community to deliver that. So the overall design of the module is based on community. It uses established dental public health principles and the evidence base, for example, NICE guidance, which has specific guidance on how to conduct community engagement. And in terms of the delivery model, we're really fortunate in many ways because we have a dedicated community engagement team, which help us to support the organisation, the implementation, the delivery, and the QA of our community-based curriculum. And I know that's something that's quite unique in the UK dental school context, but perhaps in the European one as well. And in order to create the learning opportunities for students to work in the community, we manage community academic partnerships on behalf of the school, and that's with a range of community-based organisations. And at any one time, we have active relationships with 30 to 40 community-based organisations that help us to support this curriculum delivery. One of the criticisms of community engaged healthcare models is the what Arnstein calls the sort of tokenism or empty ritual of working with the community. So that community engagement team works with the community all year round, not just when the students are active on their curriculum. And we feel that's really important. So there's that ongoing support to community organisations rather than them just being used for education purposes only. The other benefits of the model are quite wide to a dental school in particular. So it has benefit in supporting patient recruitment, and we are able to recruit specific patients for student needs aligned to their timing in the program. And we are also successful in engaging with patients from disadvantaged backgrounds as our model links together local communities with the services we provide as a dental school. So how we actually do that is through this thing we call community classrooms. So we take students out of the dental school, out into the community, and students are partnered with a local community organisation. It might be a healthcare organisation, but it might just be an organisation from the voluntary charitable sector. And we selectively choose organisations that work with disadvantaged groups or operate in areas of high deprivation. So the students work in small groups. We call them peer learning groups or sets of 6 to 8 students, and they build their experience in the community by working together and with their host organisation and its beneficiaries. They work with the organisation to really understand the community, what that means, what community assets are, what challenges their beneficiaries might experience, and understand the complexities of health inequalities and the challenges that oral health presents for people from vulnerable groups. And we feel this is really important at this stage of their undergraduate training. This occurs very early on in their programme in years 1 and 2, as it helps them to understand these complex issues, which at that point in time in their dental careers can often come across as quite simplistic to them. So what do? So the students work in a small group with that organisation to co-design a small intervention project with the organisation. The students are facilitated and supervised by an academic tutor and a dedicated community practitioner, but importantly, they're not directed to a particular answer or project aim. They have to work this out for themselves. And that in itself can be quite a challenge for students very early on in their curriculum. In parallel, they participate in what we call inquiry-based learning sessions to reinforce their learning throughout the module, and that provides a safe space for them to reflect and to connect that reflection to their ongoing clinical and professional development. So it's very much based around community exposure, and the learning is situated rather than being abstract or lacking context, which can be one of the criticisms of traditional dental public health teaching in a classroom. So in effect, it brings to life those issues that communities face, such as inequalities, power, privilege, the struggles people face in accessing services, discrimination, and I could go on. And we actively promote active listening, so students gain a deeper understanding of the lived experience of the people they meet. As you might expect, for some students, this could be quite a daunting and challenging experience for some of them. Some of them have never met somebody who might be recovering from a drug or alcohol addiction, somebody who's homeless, an asylum seeker or migrant. And we emphasize the importance of actually the students meeting them in their own environment. And this is a really good exercise for them in understanding power and privilege, because that equalizes the relationship with that individual compared to when they are, for example, meeting those individuals in the clinical environment for the first time. So as well as giving the students some practical experience of community work to build their knowledge and skills in dental public health, it also helps to bridge the gap between theory and practice. As much as it being a practical exercise, the students do complete academic assessments in this module as well. So it's a part of our as part of our core curriculum delivery, and they complete a blend of assessments, and those range from report writing, reflective writing, academic posters and presentations. So we're able to assess their development throughout the module. So I'm going to hand over to Anastasios now, who's going to talk a little bit about some of the benefits of this approach from the wider healthcare literature.
So we performed a actually quite large mixed method systematic review on the impact of this sort of model of community engagement and the impact that it has on students' views on social accountability, their empathy. And we looked across the healthcare literature internationally. And in this presentation, what we've done is we mapped the benefits to the GDC Safe Practitioner Framework and their domains. So with community engagement, students have been shown to improve their sense of social responsibility, and they improve their advocacy skills, and also they come to appreciate the role of social determinants of health. Also, under the umbrella of professionalism, they in the GDC framework, cultural competence is a big thing, and through community engagement, students may come across with different cultures, and that will improve their cultural competence and sensitivity. And they come across with people that they may have not met before from all walks of life, and that would give them an appreciation of people's circumstances and the struggles they may face. Which leads nicely to another domain of the GDC framework, which is self-management. And through community engagements, students can overcome their preconceived ideas, their stereotypes and bias for particular groups of or populations, and can also reflect on their own privilege and become less judgmental. Looking at the interpersonal skills, community engagement can improve communication and interpersonal skills of students. Students become more comfortable to build rapport with patients and members of the public, and can show a bit of empathy in their communication and establish empathetic communication with people. Also can improve their attitudes towards vulnerable and underserved groups. Coming to teamwork, which is again another element of the Safe Practitioner framework and the attitudes and behaviors the students should demonstrate when they graduate. Through community engagement, students can improve their teamwork amongst them. Also, they can appreciate the roles of other health professionals or social care professionals as they meet them in a community setting. And this can help them to appreciate the importance of interprofessional collaboration for care delivery or social care delivery. I'll pass you on to
So as I mentioned at the beginning, we were keen to finish in good time, so there's plenty of time for discussion, but we thought we'd finish off with some reflections on our model. So I think our experience is very much that this can be a really highly effective way of delivering dental public health curriculum, and importantly, in a real world context. Some of these concepts are quite difficult to teach within a classroom, things like leadership, teamwork, interprofessional communication, cultural competence. We feel that they need to develop these skills experientially, and by using the community, this is a really good approach to do that. We do know that this activity, if it's done in the right way with mutual benefit, then it can contribute to public health or improve service outcomes. And we've actually got some really nice examples which we have published as case studies and commentaries on student projects which have led to NHS service commissioning or public health action, where projects that students have commenced have been carried on by other organisations for community benefit. There are certainly reputational benefits for the school and the institute in working more closely with the community. And we were successful in winning a Times Higher Education Award for community impact in 2023. And I think the school has been recognised for its community approach. And there is some evaluation, as Anastasis has highlighted in the literature, that does demonstrate some of the benefits. But there are challenges to working with the community in this way, and those are really mostly based around resource. So it is resource intensive, just in terms of maintaining the relationships with all of the community partners, is in itself almost a full-time role. So we do need that resource to be able to deliver this in this way in the curriculum. We always talk about the squeeze curriculum. And I think one of the reasons why the model is successful at Peninsula is that it is one of those founding pillars of the curriculum. So we don't have to compete for space with other specialties or with other parts of the curriculum. It is a dedicated part of our curriculum, and that enables us to invest in community work and to make sure that we can continue to do so. I think it's fair to say that it does require further research. We're doing some of our own work on that. That's partly what Anastasis is working on at the moment in his studies to demonstrate the full benefits of the model. It is a very complex model to maintain and deliver, and that means that the evaluation of such models is also quite complex. But overall, of great benefit to students. And the one thing that we haven't mentioned, and I probably should say this at the very end, in the most part, and I can't speak for all students, but most students find these modules really fun. And certainly as a tutor, and some of our other tutors are on the call tonight, we do see significant growth in the students as they complete these community modules over the first couple of years of the programme. So I don't think we're going to say much more than that. There is a QR code here if you do want to learn more about the IP modules that we deliver at Peninsula. And we really like to open up the floor really to questions. And like we said at the beginning, we know there are lots of other examples of really innovative models of delivering education in this way. And, we'd be really keen to hear about those as well tonight. Thank you, Jenny. Are you there?
Yes, I am. Thank you very
Lovely.
much indeed. That was really interesting to hear what you've been doing. Um, Part of me wants to say, take down the slides, but actually it may be really helpful to keep them up because it might be that there'll be some details that people want to explore with you. So I've got you spotlighted for everyone to talk to. I'll happily chair this section and introduce people with questions. So I'm hoping that I can see people with some reactions and some hands up, but I might have to stop spotlighting you to do that. Anybody got their hand up? Somebody like to try the system? Let's see how it goes. We've got 28 participants in this session. Okay.
Jenny, I'm sorry. This is Jonathan. I can't
Yes.
see how to raise my hand. Am I being stupid?
Well, no. Every time it react.
React, yeah.
I think. Hmm.
You have to click on react. Sorry, not the little thing by the
Yeah,
side.
and then you can have
Yeah. Try that. But now that you've got the floor, Jonathan, just keep going. Thank you very much indeed. And
Oh, great.
when people come on, if you would introduce yourselves and feel free to turn your cameras on when you're talking. It's just nice to be able to connect with one another. So, Jonathan, over to you. And I think there's a couple of other people waiting. Great.
Yes, I didn't mean to put in there. That's great. Yeah. So thanks, Rob. That's really interesting. I'm Jonathan. I am a UK registered specialist in dental public health, and I'm based in France and also support some projects in Ireland as well at the moment. My question is really trying to picture where where your dental school is in relation to your community and how this might work in places where they're not quite as embedded in a community where you want to do the work, if that makes sense. So I guess Peninsula, I understand that the university, the dental school was set up there precisely because there was such high needs and everything. So if you could just firstly explain, where the dental school sits in relation to this, like what's surrounding it, and do you think it would work in a big inner city dentist, or what would be the challenges for an inner city dental school that maybe didn't have those communities that we want to work with so close? Would that represent a bigger challenge, do you think? Thank you.
Yeah, thanks, Jonathan. Sorry, we did a whistle stop tour, so yeah, there's lots of detail we can fill in. We were conscious of time. So the dental school is split across a fairly large geographical area, but the early year students who undertake this community engagement and exposure work are based in one of the major cities of the Southwest, which is Plymouth.
Yeah.
Plymouth is a relatively small city with a population of about 265,000 people. But I'm going to say that it doesn't really matter where the dental school is. I think there are always communities of need surrounding dental schools. And in some ways, those schools which are based in larger metropolitan inner city areas have probably got more communities of need around them than we do. So I think geography does play a part because we have to ensure that our students can easily access the community organisations that we send them to. And we have to consider travel arrangements for the students. But I think this could work anywhere. I think, we often talk about hard to reach groups, but I don't like that term because it's very easy to reach these groups. You can walk past them almost any day when you go to pick up a cup of coffee or buy a newspaper. So so the short answer to your question is I think it can work anywhere. I think what it does need though is that dedicated resource because it is very resource intensive.
Oh, thanks for that. That's really lots of food for thought and really, really interesting. Thanks so much for sharing that both.
Great. Thank you. Just working down my list here. Raki Patel, you're next. Thank you.
Thank you. That was really interesting. Rob, it was about your last point, really. It was about the resource intensity of this in real terms. Do you have a sort of dedicated people that work on this, or is this embedded? I'm sort of thinking if we could, the model is so clever and delivers such an important function as well to those communities. How could we lift and shift? What sort of resource would we need around it?
Yeah, that's a good question. So, as I mentioned, we have a dedicated outreach team, and that outreach team really manages the community organisations on our behalf. So they maintain the relationships with those organisations all year round, and they'll go and deliver their own projects with the community organisations. So, one of the things I didn't mention earlier was that once you establish trust and that relationship with the community organisation, it tends to endure and that they want students to be placed with them as much as we want to place the students with them. So developing that trust, I think, with those organisations is really important, and that actually does take a bit of time sometimes when you're starting to work with the new organisation.
So I did hear what
There's apprehension on both parts.
someone really on the champion.
Okay, and you go.
So yes, so the community engagement team is comprised of 4 individuals. They are mostly dental nurses, but we also have some community practitioners in that team as well. So those are the individuals who manage the community delivery, but each student group, so they work in these small peer learning groups of 6 to 8 students. Our year size is around 100 students, so we have about 10 to 12 groups each year. Each one of those groups will have an academic tutor who supervises the group and will conduct the academic parallel inquiry-based learning sessions with the students, just so that we can connect that sort of community experience to their academic development and learning. So yeah, so in effect, you do need 12 academic tutors each year as well. So it is quite a significant resource requirement.
That's really helpful. Thank you. It just gives me an idea how to visualize if we could move it in. Thank you.
Thank you. And just can I ask a couple of related points? So can the students go alone to the community, or does the tutor have to go with them? And secondly, one is, how do you risk assess it? Because I know universities are sort of
Mhm.
always trying to manage risk and get terribly worried about students going and connecting with maybe
Yeah.
some of the groups will be more challenging, others less so.
Yeah, I mean, that's a really good question, Jenny. And over the years, we have had scenarios where students have been exposed to the realities of the community. So, racist comments have been made, when they've been out at a community centre by individuals. So so the first thing to say is the students are always supervised. So they're either supervised by the academic tutor and a member of the community outreach team.
Right.
So we don't allow students to work on their own. And that's a stipulation of the university insurance requirements as well. And in terms of risk assessment, we've got a sort of a multi-layered approach. So at the start of the academic year, the academic tutor, the lead academic tutor, and the community engagement officer will conduct an overall risk assessment for the placement with that particular community organisation. But what we also do is ask the students to conduct their own risk assessment, depending on what type of project they want to deliver. And that's a really nice way of actually bringing risk assessment alive to students as well, because, with the best will in the world, it's a bit of a dry subject, risk assessment, but it is something that they need to graduate with some competency in. So actually, by doing it both ways, from a top-down and a ground-up approach, we think we manage risk quite well within the module.
Fantastic. Thank you. Moving on now to Stephanie Thubert-Jeannier.
Yes. Hi, everybody. So thank you very much for your presentation. It was really very interesting. I wrote my question in the chat. I come from France, in a country where the dental team is limited to dentists only. So my question relates to what you think about the concept of interprofessionality. Is it only for the members of the dental team? I have heard previously we're speaking about dental nurses. Or do you think of expanding that to maybe other health professionals and even social workers? So how do you see this?
Yeah. Well, I mean, I've only really spoken through the lens of our dental students, but we also deliver the same module for our dental therapy students. And we obviously have a community engagement team, which is a multidisciplinary team comprised of different dental professionals. We don't have one now, but we used to have a dietitian in that community engagement team as well. So we were trying to work multidisciplinary across the interprofessional areas. I haven't spoken about it, but on my slide where I showed the spiraling curriculum, there's a specific module in year 3 where students work with other interprofessional groups. So I'm just going to dive back to it here. So this one here, interprofessional working in year 3, students will work with students from other healthcare professions or even outside of health. So we've had projects in that module where students have worked with social workers, also delivering things like oral health sessions along law clinics in the community. So working with law undergraduate students. So there is a strong element of interprofessional working across the module within the actual BDS curriculum overall. But in years 1 and 2, the early years, it does tend to focus on students working directly out in the community.
And if I add, if you look at the literature, there are programs in community engagement where they blend students from different professions and they do health fair so that you can have dietitians, medics, dentists, dental hygiene and therapy students all work in a health fair and they sometimes in one of the projects when we did the systematic review, the dental therapists were working with the medics to take blood pressure, and also the medics and the dietitians were there when the students were providing fluoride varnish, so they could see how everybody is working for the benefit of the community. So it has happened, and there are examples in the literature about interprofessional learning and community engagement.
Fantastic. Thank you very much indeed.
Thank you very much.
Can we move on now to Kenneth Eaton, please? Ken, are you there?
I've now unmuted. Well, hello, everybody. I've got two questions. One's very brief, and that is, do you go to prisons? Because that's another underserved area. I know there is a prison dental service, but that would be another aspect. And the second question is, have you done any research to see if after graduation, and we've got now people who graduated from the Peninsula for what, 14 years, no more than that, 18 years, do a higher proportion of Peninsula graduates work in the community dental services rather than the GDS or private? Because that's perhaps a long-term quality assessment, perhaps. I don't know.
Yeah, thanks. Hi, Kay. Nice to see you. Thanks for your question. Yeah, good question. So the first one, do we work in prisons? Not directly. When we have done projects in the past in the community, it's mostly with community returners, or the probation service, as it is commonly termed. The logistical challenges of working in prisons really prohibit their use in these modules. The other issue is that the local prison is about to close, so there aren't any nearby ones. Yeah, but your question about the long-term destination data for students is a really good one, and that's something that will perhaps be the next part of the research. Quite challenging to do though, because I'm sure Jenny will confirm it's very difficult to track students long term. But yeah, something that does need to be done at some point.
Thank you.
Right. Interesting question. Yes. And of course, a lot will depend on what job availability there is, even if people wanted to work in one branch of the service. But it might be as much about how they work with their local communities. It'll be very interesting to follow it out. Thank you. So should we move on to Patrick Quinn now? Patrick, would you like to give your question? Thank you.
Hi, Jenny. Greetings from the Emerald Isle. How are you?
Thank you. Nice to see you. Yes.
Robin and Associates, thank you.
Nice to see you, Patrick.
The first part of my question was, can beat me to it. I was going to ask, are you going to track graduates? So you've answered that. I suppose the second part is more of an observation that all of this wonderful work, and it is wonderful work, I worry that when the very socially engaged graduate leaves dental school and they see the job over here on the left, that's the very socially highly valued job in the public dental service that pays 50,000, and they look over here to the right and they see the job for 250,000 giving Botox, where are they going to go? So I think all of this wonderful work should in a way be supplemented then by incentives in the workforce so that we maintain all of these social values we instill in our students, because so for example, here in Ireland, a lot of our private practitioners are leaving the public schemes because the maths just don't add up. So until such time as the maths add up, I think we could be wasting a lot of this very valuable education. So, maybe we need to look at incentivizing private dentists to devote so much of their time to public work, things like this,
Yeah, you've hit the nail on the head, Patrick, and there is some evidence in the literature to demonstrate that as students progress through their programs towards graduation, empathy levels and social and motivation towards social accountability actually drops. And in that literature, some of that is shaped by the clinical staff that teach them in the later years and their attitudes towards the public or public dental services or the NHS. So it is a real challenge actually in stepping up these kind of socially accountable pathways for students. We've spoken internally about, do we shift this around and put some of this work towards the end of the program? But we just feel that the benefits of the students having early exposure to people in the community is really, really helpful for their clinical training and progression. There are examples of students who work out in sort of early year settings and that's the first time they've ever spoken to a very young child or mother, and that actually brings huge benefits for them when they enter clinic and start having to, do it properly, as a clinician. So, those are the kind of like discussions we have all of the time. I don't know if you want to add anything, Anastasios. I think that is pretty fair from the
I
literature,
think it's
isn't it?
great. Yeah. And anecdotally, we've conducted focus groups with students, and the NHS is that they identify NHS or working on the NHS as a barrier to be social accountable or demonstrate social accountability. And they said, some of the students said that actually if there are incentives of us doing some community work, we would be more inclined to do it. So definitely the financial element is strong.
This is a really important part of the jigsaw, but I think, as you said, if other parts of that jigsaw aren't put in place later, this could all fall, and it's, but, it's a wonderful start.
Yeah, thank you very much indeed, and a really, really important point, which is quite fundamental to, in a sense, workforce retention, in public systems, which is a major issue. So, shall I move on to Carolina Machu Vargas, please, Carolina?
Hi, Jenny. Thank you. Hi,
Thank
Rob. Thank
Hi,
you.
Carolina.
Really, really nice to see this working. My question is related to assessments, because I'm assuming that this is involving as intensive as the module is involving a huge investment in assessment, in group works, and and with the old-fashioned system that sometimes we have in assessments. How are you handling that in this particular setting?
Yeah, that's a good question, Carolina. So there is a blend of assessment in the module. So it is a 20 credit module. So it's quite chunky, really. It's as chunky as some other things they do in the early years. So there are a range of assessments, both formative and summative. So in terms of the formative assessments, they complete some report writing, reflection. They also produce an academic poster, which they present, and they also deliver a group presentation at the end of the year in a symposium. And that's really an opportunity for them to share their learning with the rest of the year group. Obviously, we salami slice up the groups, and they all work with different host organizations. So that end of year symposium is a really good opportunity for them to share, with the rest of the cohort what they learned about particular groups they work with. So that learning is shared across all students. There's a lot of discussion of the appropriate ways to assess this in the literature, and I don't think at the moment there is a consensus on the most ideal way. I think what the literature does seem to suggest is that you need a blend of different approaches, and there's a lot of sort of formative assessment in this. So the parallel inquiry-based learning groups that the students work in with their academic tutor are also, driving learning, contextualizing the understanding, connecting that reflection to their own development, both professional and clinical. So it kind of runs sort of continuously throughout the module, both formatively, but obviously the summative assessments come right at the very end. And what I didn't say as well, sorry, the students undertake this work over 2 terms, in first year and second year. So it is quite extensive.
Thank you, Rob. Very challenging.
It is very challenging, yeah.
Yeah.
And I think nowadays we've got, sorry.
I'm learning a lot from you. Thank you.
Oh, it's fantastic. I was there for one of the, for that big symposium when they presented, different groups were presenting their findings, and it was really interesting. A lot of innovation and interesting projects. Great. So you'll have people queuing up to be your external examiner, Rob.
Jolly good.
So can I move now to Aristomenes? And then I've got a couple of questions in the chat as I'll bring in afterwards. Thank you, Aristomenes.
Thank you so much, Jenny. Congratulations for this so interesting and innovative approach. I think our horizons become widening, are wider now. So I would like to ask you if you have included an assessment system of oral health policies in terms of social accountability of dental care, of dentistry, as well as an assessment system of dental schools curriculum regarding social accountability. And I have the idea that, as a comment, I would like to say that some people, oral health professionals, say a lot about social accountability, and sometimes where they are in key positions in health system or in the government, they forget it. And so maybe it would be really interesting to see what happens and give extra motives to for people to adapt to this so important idea. Thank you so much.
That's good.
Do you want to take that one? Yeah, absolutely. I mean, I think those are very good points. I mean, I don't want to put Jenny on the spot, but I think maybe one of the first steps would be perhaps revising the AD position statement on the socially responsible dentist, because that provides a hook for all European dental schools to strive for. But in terms of your question, have we done any policy mapping? Not in this particular undergraduate module, and we're not focused on that aspect at the moment in Anastasos's work. But I think it's a really important point and actually something we can take away from tonight.
Yeah, thank you.
Yeah,
Okay,
thank
it
you.
would
Good
be
points.
it would be good idea if you like to change some ideas about that, because you can do so much and you can contribute so much in our work. Thank you so much.
Mm.
Thank you.
And I think the point about the guidelines are in a sense led by ADE. I suspect every now and then there'll be a desire to update them, and I think it's keeping an ear to the ground there and saying actually, when can we contribute, and perhaps having a list of things in the back pocket that might need to be picked up in any new guidance. So yeah, I think that's a good point. There's a couple few more questions. So we've got a three-part one from Anna Bevan in the chat. Does the program help students from minoritized backgrounds in the Southwest apply for dental school? So that actually any of the contact with children, does that help with, I suppose, widening participation into the different dental programs? Do you have a trauma-informed care in your module? And the third one is around, do you have mechanisms to support students who themselves may have come from a vulnerable background and are doing the module and actually struggling to come to terms with, in a sense, their privilege? So really interesting reflective comments from sort of widening participation through to people who actually may have come from more challenged backgrounds and managing trauma on the way through. Do you want to pick that up? The question's at 1733 if you want to just refresh and look at it.
Yeah, so I mean, I think those are all fantastic questions. In terms of trauma-informed care, yes, that does feature in the module. In fact, Plymouth has a trauma-informed network that student groups have worked with over the years, so that does form part of the work, and it is something that we cover in the preparation for the module with students. In terms of promoting access to the dental school for local people, we haven't really looked at it in that way. We obviously have a widening participation program like most schools. One of the challenges for us in the Southwest is that we have less students per head of population applying to university than any other region of the UK. So there is sort of a very active WP program in the school. And I mean, to be perfectly honest, there's a lot of crossover of the work that we do in this module with that WP team. Some of our community projects are WP based. So we have a specific school in Plymouth which promotes health careers. And our students work with that school promoting careers in dental care across the entire spectrum of the dental team. And those have been fantastic projects. Again, it's that sort of tracking the outcomes of that long term is definitely more challenging. And I've forgotten what the final part of that question was.
About vulnerable.
Oh, vulnerable students. Yeah. So that's actually a really good question. So I would like to give you an actual example of that. So one of the groups that I supervised last year was working with children in care, and one of the dental students in my group was actually came through that pathway themselves. So, we obviously have support mechanisms in place for students if they are finding things challenging or difficult. But actually, that student really embraced working with that group because he felt he had sort of he had lived experience, and I think the rest of the members of his group found that really beneficial to get real insight into some of the experiences of children in care. So I think it can work both ways. It can be both a positive and a negative.
Thank you. We've got a number of questions from Hadi, so I'm going to select one of them here. So how can dental schools ensure that community engaged learning doesn't inadvertently exploit vulnerable populations, but instead empowers them?
Yeah, I mean, again, a great question, and I think we're very sensitive to that. So we try to avoid tokenism and sort of what's called empty ritual in the literature. So having a community engagement team that can build trust and relationships with the organizations is really, really important. And it's not the case that we kind of like parachute students in and then disappear for the rest of the year. That community engagement team and the school continue to work with those community organizations throughout the year across a range of projects, not necessarily just with students. And I think that sort of community of practice, if you like, or sort of ecosystem really benefits the community as well. But it is a real issue, and it's something that I think all educational institutes have to be conscious of. It's not the case that you can just use the community for your own benefit. It has to be of mutual benefit.
Thank you, Rob. Really important point. And I'm going to take one of Hadi's other questions as a sort of final question. And that is for somebody who hadn't engaged with this before, but wants to begin to explore it further, what would be what would you recommend as sort of first steps?
Is this person in an educational institute or just generally?
I presume they're involved in education. Yes. If you want to begin to do that within an educational institution, within your undergraduate program, where would you start?
I really do think you need leadership support to develop modules like this. So, talk to the dean or the head of school or the head of curriculum, and talk about the benefits of this type of approach because it does require resource and funding to deliver. And like I said before, often in a very squeezed curriculum where there are always more things to add into the curriculum and often never anything to remove. So it's kind of finding the space in the school to do this. Like I said, we were very lucky, really. The founding dean of the dental school here had the vision for community engagement being an integral part of curriculum, and that's allowed us to build that over the past 14 or so years. But I think leadership support and then obviously building relationships with the community because they are the classroom, and unless you have a relationship with those, it's very difficult to deliver.
And I think you need a participatory approach when you develop these projects. You cannot just dictate what the students want to get out of it. You need to work with communities and see what they want, and the community organization, how the university can support them in the work they do in the community. Definitely.
Yeah, so it sounds like it's a bit of background work with local community, getting on top of the literature, and then using that in talking to deans and leaders and exploring what's possible. And maybe dip your toe in first of all.
Yeah, I'll just add, Jenny. I mean, I've been involved in this for a very long time now, almost 20 years, and we've never had a community organisation or group decline working with our students. So I think that gives a sense of, the benefits the community itself sees in this approach.
Lovely. Well, I think this has been a fantastic session. It'd be fantastic to actually get it written up and perhaps to incorporate in some. I know you've already published on this, but actually to have a paper that provides an overview on this story with key references, I think it would be fantastic. And in closing, I would say that we're also interested in looking at our European workforce. We're also interested in looking in training, as in specialty training. So those are topics that we're going to be covering either in webinars like this or in our meeting in Rome. So I look forward to seeing some of you there. We may manage to have a webinar beforehand. If we can squeeze one in before then, we will. And do send any suggestions or ideas to me, and I'll put my email in the chat, but I think you probably all know how to get hold of me if you want to. That would be great. So a big thank you to you, Rob, and my I was going to give you the wrong Greek name for a second, Anastasius, for your presentation this evening. That was absolutely fantastic. And you can see from the comments in the chat just how much people have appreciated it. So I wish you all...
Jenny, just to add one thing
please.
in. If anybody would like to reach out because they want to start something like this, then I would be very happy to help them.
Fantastic. There's a wonderful offer. Well, thank you all. Have a very good evening, and I look forward to seeing you again soon. Bye-bye.
Thank you.